So this data lend increasing confidence that patients with high-risk muscle invasive who have persistent ctDNA negative status after cystectomy, maybe even thinking maybe spared from adjuvant treatment. So that's something that we will see after analyzing the results of this trial. So that's not the only trial. There has been other trials presented. So the BOLGA study is a study that is exploring combination of immunotherapy and ADCs, enfortumab vedotin. This was presented at ESMO 2024. And here again, it was confirmed that patients who were ctDNA negative or who had ctDNA clearance, they had improved event-free survival. But patients having ctDNA positive with no clearance, those patients were upstaged. Obviously, this trial is ongoing. Still, we don't have the results. But in this trial, they use a different platform. That's something. The Natera Signatera was not used. They use a different way to identify DNA in blood. That is the methylation sequencing. So the methylation of DNA, the pattern of methylation can help us also to monitor cancer. It's a different way. As mentioned, there are different tests. The Natera Signatera, there are the Garden, there are the Grail, so many different platforms. Another trial that was reported, this was a single-arm trial. This was reported by the Danish. So patients with ctDNA positivity after surgery, they receive atezolizumab, and they report that 55% of patients converted to ctDNA negative, meaning these patients that you didn't know what to do. Do I need to give adjuvant immunotherapy? The ctDNA help on deciding, okay, you need to receive immunotherapy. And when receiving atezolizumab immunotherapy, being ctDNA positive, those patients became negative. So helping to identify patients that might benefit. And then the last news on the ctDNA has been being able to go back, rescue samples from the Niagara trial. And as you know, the Niagara trial is a trial that has been done on also not in high risk. It has been done in muscle-invasive bladder cancer. This trial was comparing the combination of chemotherapies, cisplatin gemcitabine plus durvalumab, that is a PD-L1 inhibitor, before surgery. Here you can see the radical cystectomy, patients receiving 4 cycles before the surgery. This was compared with the standard of care, that is giving neoadjuvant chemotherapy only. These patients randomized to each one of these arms, then they had the surgery. Some received adjuvant durvalumab or the others didn't receive anything. This trial was designed in 2016 where there was no role for adjuvant chemotherapy, immunotherapy. There was role for nothing. So this trial that you know now it has level 1 evidence. That's the way that we need to treat patients with muscle-invasive bladder cancer. They need to receive chemotherapy and immunotherapy. Patients need to have adequate renal function. There is also an option to give a split dose platinum if they have more than 40 mL per minute. And this trial led to a survival improvement in patients receiving chemoimmunotherapy followed by adjuvant immunotherapy after surgery. So what was presented at ASCO this year, and this was presented by Tom Powell, is that this plasma, they were able to collect they were able to collect plasma before starting the treatment, during the neoadjuvant period, plasma before cystectomy, and then plasma after cystectomy. And then what this trial did show, as you can see here, the blue is the percentage of patients having ctDNA positive. This is baseline. Here is when they receive neoadjuvant chemotherapy. This is before radical cystectomy, the time of cystectomy, and then in the follow-up, post-radical cystectomy, when some of them were receiving adjuvant. What is in here is that we see that the percentage of ctDNA positivity, is going down. So going down to 22% after neoadjuvant treatment, and then after surgery, it's going down to 9%. An interesting observation is telling here that patients that receive neoadjuvant chemotherapy plus durvalumab, the rate of decrease in the ctDNA from baseline to pre-surgery was higher, 39%, compared to patients receiving chemotherapy, confirming also the value of adding immunotherapy in the neoadjuvant setting. So this was something to support that ctDNA is helpful to identify benefit of drugs when this is in clinical trials. So also the clearance did show higher benefit. Patients that the ctDNA disappear while being on these neoadjuvant trials. And we see here in the post-cystectomy, the ctDNA detection was prognostic. So the same that we have seen before. So ctDNA is helpful in terms of prognosis, helpful on the rate of decline is telling us that the patients are going to do much better than those that you don't see a decline. And obviously, now the ctDNA is built in several different trials. So here is the Alliance adjuvant trial. So trying to improve outcome in our in patients having muscle-invasive bladder cancer. And as you can see here, the ctDNA is implemented before deciding to give adjuvant. You can see here the patients that have ctDNA positive here are randomized to the standard, that is nivolumab, or an intensified adjuvant therapy, that is nivolumab plus relatlimab. And also patients that are negative, these patients are high risk, are randomized to immediate treatment, nivolumab, or surveillance, monitoring the ctDNA, and in case the ctDNA becomes positive, receive nivolumab. I know that is a complicated trial, the first time that you see that, but this trial will further confirm the value of using ctDNA on deciding, for example, if you need to intensify the adjuvant therapy, or if you need just to only monitor patients and treat at the time that the ctDNA is coming positive. So saying that we can save treatment options for patients. You don't need to treat these patients that are maybe continuously negative, or maybe you need to treat anyhow patients with ctDNA with nivolumab. So he's trying to answer several questions. This trial is accruing, and hopefully it's going to provide some new inputs on the way to use the ctDNA. So I think that we are on time. So that's my last slide. This is summarizing everything that I have been presenting. So those are the different settings where the ctDNA could be used. So yeah, you could see here the setting where now all these tools are being used for early detection, for screening. I have not discussed, but also the urine ctDNA can be used to monitor recurrence in patients with non-muscle invasive bladder cancer. So urine is also a place where we can check the DNA. And here we have said we can follow the ctDNA to see the kinetics under treatment, follow after surgery if the ctDNA is coming negative. And when patients, unfortunately, they develop metastatic disease, we can detect relapse even before that is evident by imaging. We can monitor if there are changes on the genomics and implement or changing therapy based on the findings that we see on ctDNA. With, as mentioned, there are different platforms just to do all these things. So with that, I would like to thank Stephanie and Beacon for the opportunity to invite me to share all this data, and I'm open to questions if I am able to answer, because as mentioned, this is an emerging area in bladder cancer and other tumors. So thank you very much for your attention.